Good afternoon. Thank you for coming to try to learn about baroreflex activation. This is something that is relatively new to vascular surgeons and heart failure. That's a disclosure. Now I would like to be able in the next 10 minutes teach you what this is, how you do it, and why as vascular surgeons we should embrace this technology to assist our heart failure team. This is probably my favorite slide of the whole presentation, and I use it quite often when I'm presenting to referring physicians and sometimes when I'm talking to patients. When you talk about the clinical course of heart failure, we know that as heart failure progresses, the quality of life will decrease. Somewhere before you can initiate GDMT, these patients had a lifestyle that structurally changed how they behaved and how their heart is going to perform. So you get the patients and you start medical therapy, which we have multiple guidelines and we do what's best for the patient. But we have to understand that the biggest challenge is compliance. And it's not only the problem with compliance, now you have a medication that only affects one thing. It also cannot adapt. If you give a medication to bring the pressure down, it's going to bring the pressure down whether the patient needs it or not. All the way at the other end is where you have advanced interventions. And that is one that you take away the compliance issues, but now you made a big commitment. Now you have an LVAD or a transplant. Somewhere in the middle, for class 2 and 3 patients, is where we can really affect their outcome, their morbidity, and their mortality. And this is where device therapy is going to work. My understanding of device therapy is that most of it right now will be something that affects only the heart. ICD is going to affect mortality. CRT is going to affect morbidity, but they only work on the heart. And when you think about heart failure, it's not just the heart. It's called heart failure, but it's the whole cardiovascular axis. Now we have a device that we can use on that same place, but affect the whole cardiovascular axis. So patients with heart failure have a significant autonomic imbalance with increased sympathetic tone, decreased parasympathetic tone, and obviously heart failure symptoms. The question is why that happens. And it happens because the baroreceptor is not stimulating adequately the brain. The way I present this to physicians and also to patients is talking about air conditioners. If the thermostat is broken, it doesn't matter what the rest of your air conditioner is doing, it's not going to work. Now, what's the question? If we stimulate it electrically, can we rebalance the autonomic system? And more importantly, can we actually normalize the cardiovascular physiology in these patients? So for that, we did a study. And it was a 1-to-1 randomized study in which we stabilized the patient's medications before enrolling, and then they were enrolled randomly into either medical management or unchanged medical management and barostimulation. That led to our approval in 2019. And since then, we've been obtaining market data, which will be released talking about CV mortality as well as the heart failure morbidity. We know from the paradigm study that decreasing NT-proBNP for at least 10% will lead to a significant reduction in morbidity and mortality. We obtained, with barostimulation, 25% reduction of the NT-proBNP. So if we're going to play in the same sandbox as other devices, we need to see how we compare with them. And when we look at it, our patients actually were able to walk much further than the second best. Their quality of life improvement was more significant, as was their heart failure classification improvement, with 13% of them actually improving 2 or more levels of heart failure. So that actually proves that Barostim itself will improve heart failure symptoms by increasing the parasympathetic tone, decreasing the sympathetic tone, and hence decreasing heart failure. So that was what it is. Now let's talk quickly about how we implant the procedure. For most vascular surgeons, this will be an easy procedure. It's minimally invasive, takes roughly about an hour. It's a great case to book as a first case because you can go back with your second case without having to wait for the patient to wake up or obtain hemostasis. We have a generator and a lead. It gets tunneled and then it gets managed by a management device, which is radiofrequency. Those are the two structures that we use. The implantable IPG, which goes in the chest and is about the size of an ICD, and the sinus lead. Before the patient gets scheduled, they see any vascular surgeon in the office, and we do an ultrasound to show that there's less than 50% stenosis. During the procedure, we actually use ultrasound to identify the carotid bifurcation, and then we mark the incision in the neck, and we mark the pocket. The reason for this shape of the pocket is that we need to implant the IPG, but we also need to put the excess lead medially, but lateral to where a mid-sternotomy would be done. We make the incision, which is 2 to 3 centimeters. The closer you are to the bifurcation, the easier your exposure is going to be. Less traction, less nerve injury. Often we ligate the transverse facial vein, and we only expose the anterior wall of the bifurcation and the common carotid artery. Then we have to map, and during the trial, we started with A, and then did a systematic mapping, and whichever your system is, just try to always do it the same way, and that way you can obtain better results. I used to go A, B, C, D, E, but you can go in any way you want. Ultimately, if you get a good response in A, you do not need to map the rest of the carotid. So it's something that you can just implant right there. And that would be the default position if you do not get a blood pressure or heart rate response. The tunneling is simple. We tunnel behind the sternocleidomastoid muscle, and we try to go out through the bifurcation of the two heads, which when we make the pocket, you can actually see that bifurcation of the heads and go in between them. This is the actual electrode with the disc around it. This is 2 millimeters. This is about 5-6 millimeters, and we suture around it 5 to 6 sutures, being careful with your medial sutures when you get close to the nerve of Herring so that you don't affect the efferent loops of that nerve. We build a strain relief loop in the neck so that when the patient is moving the neck, it doesn't tug on the lead or the carotid. And ultimately, we close with just 2-layer closure, usually 3 ovicril and 4 monocryl, and then Dermabond in the skin. So that tells you the how, which as you see is very simple. The most important question is the why. And the easy answer would be why not? As vascular surgeons, why would we walk away from another procedure that we have the best tools to use? I don't need to teach anyone here how to use an ultrasound. I don't need to teach you how to expose the carotid. If you injure something during tunneling, guess what? You're going to call a vascular surgeon. So you're already there. We actually have the best tools. The second thing about this procedure is that it keeps us valuable in another service line in the hospital. Obviously, during the years, we've been involved with trauma, we're involved with transplant, general surgery, orthopedics, but now you can be an intrinsic part of your heart failure therapy. If your hospital does not offer LVADs and transplants, now you have one other procedure that you can offer the patient before having to refer to another institution. And from the feasibility of the procedure itself, it's a short procedure that currently is crosswalk to a carotid endarterectomy. So it pays the same as a carotid endarterectomy and is about 21 RVUs for the procedure. And with that, I'll leave you guys with Dr. Clem Darling to present some patient selection and a case.